So if you have some inhibitors, even the stones are even precipitated in the TD, in the background, you block the inflammation nearby. So you can prevent the renal fibrosis and progression of the renal disease. So a lot of studies are going on in this. Now, still the primary kidney or primary liver is available. There are few studies where the hepatocyte has been transplanted. Hepatocyte has been transplanted in the existing liver to identify that it can host inside the autologous liver and to give some therapy. This is going on. The study is being published, and then there is a aluminium citrate is new agent which has been found in the oyster rat model. If you give them, if the patient is eating glycoma, a lot of muscles get deposited, they reduce the tubular injury, reducing the fibrosis in the kidney. So these are some areas of the treatment added the aluminium liver and the kidney is available in the market. As I said about the IL-1 beta blockers, which ultimately prevent the inflammations. So the study data, hepatocyte cell data. See, after the hepatocyte transfusions, these component crystals in the liver cells are reduced significantly. Obviously, this is a rat form. Now there is a new understanding. This is very interesting, which this new article is given to me by one of the researchers. But this AGD, this enzyme, there are some molecular chaperone which activity has been folded in a specific structure, and this enzyme activity depends on. So if this chaperone has been identified as ENHJ, this prevents the functionality and folding of the enzyme. Now the research is going on if we can prevent this J inhibitor, then the functionality of this enzyme, if the patient has no synthesis, is a significant. So this is another area where the scientists are thinking so that we can tackle it. So this I would like to conclude, but before I think, I would like to insist on that in this community, in our whole country, there are about 12,000 primary and Oxaluria disease. We don't have any structured society to study this disease. Last time in the ISOT conference with the initiation of Professor Binayak, Indian Society on Primary Hyperoxaluria has been formed. But take it as in its infancy to do dedicated research. I salute the initiative by Binayak because he teaches the time Dr. Pamidi also. I call him Kanishka, he is a very good friend of mine. Okay. So to make the people aware regarding all these diseases, but there are a lot of people left. We need much more awareness among the hospitals, doctors, clinicians. You need awareness about the medical fraternity, and you need to have a platform to organize research on the disease. To do something, do some positive things so that we can improve the lifestyle of the people. As I said, the PHSI has been formed. PHSI's activities are limited to 2 cities only. So we can add some values to these activities so that we can add some conferences. All the international leaders can come and discuss their research data. And obviously we can collaborate with Kanishka foundations and Foundation of Oxaluria and Hyperoxaluria foundations from the US who have worked with that. There are some photo galleries, but this Kanishka foundation did a lot of awareness programs. I'm really happy to see this again. And I let me inform that we have one foundation for the Indian Society. This does a lot of patient awareness programs regarding kidney disease and Hyperoxaluria, the major class of the nephrology. So I am ready to collaborate with the Kanishka Foundation. And there are some, we keep numerous camps in different parts of the country. Even in the Bhutan, in the rural Bengal, we need a lot of camps regarding kidney disease awareness. So we can have a joint discussion so that doctors, those who participate in these camps, they can have some idea regarding this disease. This is one of the photographs of one of the camps we did this year. And obviously, the Oxaluria and Hyperoxaluria foundations, we are doing based on the US, they need a lot of awareness program, locally inviting patients. Anybody can participate if they go there. So this type of activities are needed, and obviously the CAD which has been our current story, and the basic scientists who work this way to develop the machine and develop the challenges that we are facing. Thank you very much.
Thank you, Dr. Pratik Sengupta, for your wonderful speech. I will now request, please don't go away. Please don't go away. Just give me 1 minute. May I call upon Ms. Shoma Shah, who is the aunt of Kanishka, to give a memento to those who are going away, please, first. Memento, please. Sir, to memento me. Memento. There's a memento for each one of you.
So my experience is personal experience is limited, and I shall be telling mostly from my knowledge, and apologize me if some of my slides. Diagnosis is tough. A high plasma oxalate of more than 100 micromole per liter, or deficiency of AGT enzyme in frozen liver biopsy which has a high sensitivity of more than 95% is the gold standard, and AGXT gene sequencing which is indicated in patients with phenotypic characteristics of primary hyperoxaluria 1, prenatal diagnosis by coronary villus biopsy, or screening of siblings or parents of the intestate. Now, to my knowledge, these assays were not yet available in our country, but however, Dr. Calcutta just told us that in Ahmedabad we are able to do this enzyme assays recently. Now, for a clinician, we should know when to suspect hyperoxaluria. When the first line workup for regular neurolithiasis is negative, the first line workup will rule out hypercalciurias, hyperbituminosis B, distal renal tubular acidosis. When these are negative, then think of primary hyperoxaluria. Next, to complete the workup of a rare metabolic disorder causing nephrocalcinosis. Third, for referral patients who present with reports of oxalate crystals in the urine. Mind you, a single report of oxalate crystals in the urine is not diagnostic of hyperoxaluria. To diagnose it, we need a 24-hour urine sample which required more than 2 or 3 times. And when primary hyperoxaluria is a differential diagnosis. Now, I would like to share some of our in-house experience. Recently, we came across a 5-year-old male child with recurrent neurolithiasis and hematuria in the OPD. What have we done? We have sent our first-line investigations, ruled out hypercalciuria, idiopathic hypercalciurias, hyperuricosurias, and we are waiting for our reports. If these come negative, then we would go ahead and look for hyperoxalurias. The picture here shows basically a 4-month-old infant. She was just 4 kg of weight at 4 months. So there was evidence of failure to thrive, polyuria, and CT scan abdomen revealed nephrocalcinosis. In this case also we tried to rule out hyperoxaluria, and this child had some additional symptoms also like bony overgrowths over the joints, and ultimately it turned out to be a neonatal onset multi-system inflammatory disorder. So what is primary congenital hyperoxaluria? We all know by now. There are 3 types, it is already discussed. So what is the prevalence? 1 to 3 cases per million population. At least 1% of the end-stage renal disease in pediatric population is attributed to primary hyperoxaluria, and this is by the European and Japanese studies. It is more frequently seen in populations where you have consanguineous marriages. Based on a 10-year US registry, they have shown that there is a significant delay of diagnosis in 42% of the patients, and 30% of patients are diagnosed only when they have already reached end-stage renal disease. So what is our Indian data? By PubMed search, I just found few isolated case reports and case series. Mostly from the central institutes like AIMS and PJ Chandigarh. From AIMS, they have reported 3 Indian children, 6 months, 18 months and 6-year-old, who have already presented with end-stage renal disease and having primary hyperoxaluria 1. Then there was an Indian family with 2 affected siblings with inherited AGXT mutation. Parents also had it and the children also had it. There was a short study regarding the etiology of nephrocalcinosis in northern Indian children, and they have found that 50% that due to distal artery, idiopathic hypercalciuria and hyperoxaluria constituted only 7.5%, which was the second in row. There was another case from PJ Chandigarh that showed an 18-year-old male with recurrent abdominal pain and passage of stones in the urine. CT scan abdomen revealed a bilateral symmetric nephrocalcinosis with a preserved kidney size, which is more suggestive of primary hyperoxaluria. Renal functions were however deranged at presentation, and chronic kidney disease. However, few recommend that we can avoid fruit juice, spinach, peanuts and cocoa in these children. Surgical management, always endoscopic procedures are preferred rather than open procedures, but mind you, avoid any surgical intervention in uncomplicated renal stone except when there is infection, obstruction or multiple urolithiasis. Renal replacement therapy has already been told you in detail. So, what do you do in enteric hyperoxaluria? Besides this conservative management, we also need to reduce the dietary intake, low fat diet with calcium supplements in meat. Why calcium? Calcium basically binds to the oxalate and inhibits the intestinal absorption. And why low fat diet? Basically in malabsorption, it is the fat and the size, the fat binds to the oxalate to form a soluble component. Though it is not absorbed in the intestine, it requires the intact colon to be absorbed. So when it reaches the colon, there is high levels of absorption of oxalate and there is systemic hyperoxaluria. So cholesterol might be helpful and probiotics as discussed are still in the research stage. So in a nutshell, it is a rare autosomal recessive involuntary glycosylated metabolism with deficiency of the liver-specific enzyme AGT. Overproduction and excessive urinary excretion results in urolithiasis or nephrocalcinosis. As the GFR falls subsequently, there is systemic accumulation and that results in oxalosis. Diagnosis depends on clinical, radiological, urinary oxalate, DNA analysis and enzymology. Early conservative therapy does conserve the renal function, which I always like to emphasize. And whenever in CKD stage 4 and 5, the best outcomes are with combined liver and kidney transplant. So think of primary hyperoxaluria if you have to diagnose them. Early conservative measures should be instituted as soon as possible, and patients should be informed regarding their lifelong management. As you can see in this picture and infer that how does perseverance space. We need to be dedicated, we need to be perseverant to find and look for hyperoxaluria. And I would like to really request the organizers if they can tell us the way out, if they can support us when we want to screen patients with hyperoxaluria, like monitoring wise and show which that would be adequate. Thank you.
Thank you, Dr. Momita Samathu. That was very nice of you. And definitely we will keep in touch with you. And if there is any requirement of any patient or any information, we would definitely like dissemination of the same. May I now request Mr. Chittaranjan Shah, Kanishka's grandfather, to say a few words.
Namaskar. Ladies and gentlemen, I am much impressed about your presence in this auspicious occasion. Being my grandson, though he departed this beautiful world, but he made me acquainted with other side globe, people of the globe. This is a great achievement towards me and my family. I congratulate all of you for attending this inauguration function. Other speakers who will speak, that's why I have shortened my speech. Thank you very much.
Thank you, sir. May I now call upon Dr. Nageswara Pamidi, who is the visiting clinician, Department of Nephrology in the Mayo Hospital, Mayo Clinic of USA, to say a few words. It seems that Dr. Nageswara is now, he is not there. He will be coming in a few minutes and he will have his speak. If you have any questions to ask Dr. Samathu, you are welcome. Since there are no questions, we will ask Dr. Pamiti to speak.
Was the primary approach to what Dr. Prateek Singh has already spoke to you exhaustively. There's a good coverage about this rare disease. So, regarding my work experience at Mayo Clinic, the number of suspected cases of primary Hyperoxaluria in the entire world, basing on today's statistics, may come to around 25 to 30,000 cases of primary Hyperoxaluria. That is the main reason, and probably United States may get around 500 to 600 cases of primary Hyperoxaluria. So to study about the disease, you need large number of cases. So that is the main reason why the primary Hyperoxaluria group of Mayo Medical Center has come up with this rare kidney stone consortium. They have collaborated with many countries. Almost they get blood samples from almost 40 to 45 countries, and they have a huge database of this primary Hyperoxaluria patients, around 550 patients of them, and around 20 patients, 20 to 25 patients contributed from India. Of these, I have seen around 3 to 4 patients. All of the patients, I think 4 patients, all of them are unfortunately diagnosed after kidney failure has set in. So at least with this primary Hyperoxaluria awareness campaign, what Mrs. Saha has initiated, taking lots of efforts with great determination, in spite of living at Czech Republic, to conduct a big awareness program in Calcutta needs a lot of courage and determination, which she has successfully, I think, has started in a very positive way. So after this awareness program, at least whatever primary Hyperoxaluria cases are getting detected should be detected before the child goes into renal failure. Compared to what we know, Indian case scenario is all the primary Hyperoxaluria, almost 90% of the cases are getting detected once kidney has failed. So not much use economically or research wise. So the primary aim of this awareness program is to create, there is a disease called primary Hyperoxaluria, which is an orphan disease, but the patient or the child who gets the disease is not an orphan. So even though the disease is an orphan disease, a rare disease, for the family it may not be rare. It is common to them. So creating this awareness is a beginning, and it goes in a long way to detect the cases early, so that treatment can be started early. At least in 30 to 40% of the cases, what Dr. Prateek Singh has told, pyridoxine